We have gotten a dispensation to go to 12:30 if we have want to have a brief question period. So I see we have that you voted with your feet. Okay, so we'll start here and.
Thank you.
Yes.
Yeah, quick question as it pertains to the data, because from the family perspective of what data means, maybe a quick question for the audience. Everyone in here in this room, with the recognition, the awareness that at some point everyone will die, please be seated. Well, it's pretty good that that's almost unanimous. I've made a lot of good friends over the past couple of days here. But a question I would have, because from the data standpoint, from the patient's perspective, this is a little bit of what this is like, that even with the friends that I've made, when it's your time, when you're dying, am I allowed into that room? Me. I would guess the answer is no. Brittany, and I'm not talking about medical aid dying, I'm just talking about our normal dying process, whether that's in hospice care, wherever that is. When Brittany went through this process, she filled out the forms. Her physicians filled out their forms. That was given to the state of Oregon, and the state of Oregon reported on that. The statement of tasks of this workshop highlights the research and the data so that we can talk about these things. And to be clear, we can fix and improve things, only those things that we measure and track. So data is important, and I'm supportive of that. Brittany, I want to suggest that if there's an outside research group that wants to follow up along the process, approach a family, gain better insight, I'm all for that. And Brittany probably would have allowed for that. I mean, she had the media, national media, in her living room interviewing her. But there are others, individuals, that would not. This is a private matter, a person's death. So along those lines, I would ask the panel, the question being that if there's an outside research group that is interested in pursuing this and researching that, I would say that that's appropriate. However, having gone through this with Brittany, I would warn against any effort to bake into legislation the burden that we already see with that Katrina mentioned that goes on in Oregon, that trying to bake that into legislation, that's not appropriate. The burden on the family can be significant, especially that terminally ill individual. So that's kind of my question to the panel, to maybe comment on that idea of should this be something, and maybe there is a certain base amount of data that we gather through the process that we have in Oregon, in Washington, California. But for example, the question, who picked up the medication? I picked up the medication for Brittany, just like I picked up every other medication for Brittany. Is that significant? What learning do we glean from that? And the issue that I have with this, after gone through this firsthand, and also the multitude of experience from family members who have approached me, there always seems to be this underlying idea that there was something nefarious that went on. No. There were 69 deaths in 69 deaths in the state of Colorado. And to me, after having gone through this experience, I would submit that those were amongst the most protected deaths, because there were two physicians looking at, they had to go through a protocol, versus somebody who just gets a prescription for Dilaudid. This is for pain control. This is enough, and this is at the bedside. This will put somebody to sleep for good. No process to get this. So I just would like to issue some caution regarding what type of data collection, because if it does not benefit the patient, and obviously that's who I would be advocating for, be careful with that. If it's just for research, so some Professor Chalk Dust at the local university can make up some study about something, make sure that does not intrude or is a detriment to the patient, to what they're going through. And so as it applies to that, the question, would be, should this be taken up by independent agencies to, ask for permission and follow along with these families versus trying to bake it into the legislation? Thank you.
Anyone? Response?
I'll just comment very quickly on that. So 2 things. One, I'm not going to acknowledge whether or not Brittany was reported to us because we have strict confidentiality. And I start by saying that because it's really important to figure out the role of government, and when we are collaborating with external researchers, what does that mean? And at least in terms of this law, we do not have a list. I mean, I do have a list of patients, but I am not going to give those to anybody outside. So there's sort of 2 points to that. What is the role of government? And I alluded to that earlier around monitoring, compliance, sort of that oversight piece, and again, not regulation, there's a distinction there. And what research do we need? And I would also posit that we need research not just on this specific, the Death with Dignity Act, but that all of the aspects of end-of-life care. And so I highly support having more knowledge of that, whether it's done through hospice organizations, whether it's done at a university setting where they have a cancer neurologic clinic for those patients who've got ALS or others. This research understanding decision-making is really important, but I would say that that does need to be distinguished between what the government does, and we have made it a policy that we don't directly collaborate with outside researchers because of that confidentiality, that would often mean you're collaborating, therefore you're providing the names of patients and families to others. And that's something that we are ironclad about. And like I say, I don't even admit cases that are public, et cetera, whether they've been reported to us or not, because of that very, very strict confidentiality.
And mindful of time, I would just remind people to keep the questions as focused as possible. Mr. Kelly?
John Kelly, not dead yet. Dr. Hedberg. The OHA is tasked with the monitoring compliance of the program, and yet you neither have the authority nor the resources to investigate. In the interest of transparency, could you include in the annual reports cases of violations of safeguards, such as Patrick Metheny, who did not self-administer, the attempted killing of Wendy Melcher? The 2 nurses were able to shield themselves from public prosecution by being secretly dealt with by the Oregon Nursing Board, and the case of Thomas Middleton, who moved into the home of Tammy Welcher, a crooked realtor who, after his death, defrauded his estate and put money into her account. Such reporting would enable a more balanced public debate and would prevent proponents from making the ridiculous assertion that in 20 years there have been absolutely no problems with the program. Thank you.
So thank you for the question, and I think that it really clarifies or delineates exactly what our role is and what our role isn't. I know there have been a number of people that would like there to be more oversight or regulation. So when I say monitor compliance, it really is monitoring all the steps up to the point a prescription is written. Exactly has been outlined in the law, and that was written in administrative rule. There is nothing in the law that talks about, and again, I put that up as one of the gaps in the legislation. There is nothing that talks about what happens after a prescription is written. That the law is absent. As was alluded to a minute ago as well, at least in Oregon, there are no resources that are given to us at all, even for the data collection that we do. We do that as part of our standard vital records. So I don't dispute that there are people who would like there to be much more oversight. The question is, as a government official, I have to carry out the law as it is stated in black and white in Oregon. If there are cases where someone is concerned about coercion or potentially cases where they don't follow, where it might mean criminal intent, those are taken care of within the criminal legal system, not by a governmental agency. And so again, I understand concerns about this wanting there to be potentially more oversight. And so while I sympathize with that, what I say is that if people really want that, they need to change the statute. You don't really want government officials to be acting above and beyond sort of the clear confines. It's the role of different...
There is no reporting to criminal authorities, and your silence on the matter means that people think that it's entirely safe.
So I'm sorry, the reporting, so you mentioned a number of cases. I understand those have been in the press, but we don't hear about what happens. I'm not the person who would hear what happens after a prescription is written. So again, just to be clear about the information that we get, and other than, if you will, what's been reported about in the blogosphere or whatever else has been reported, it's not, I hate to say it's not my job, because people often say that, but I think being very clear what the role of a public health agency as written in the statute versus what are the role of other aspects of government to provide the oversight. If there is a clinician, and I had mentioned, actually, I went quickly because I was running out of time, we have reported 22 physicians to the Oregon Medical Board for not following the steps that were outlined in the statute. They have an investigatory arm, we do not. So again, some of the other examples that you bring up, and I won't go into details because I'm not an expert at investigating what happens in those situations. I'm an epidemiologist. So again, if that kind of oversight is wanted in different laws, I would say that that is something that needs to be changed in the statute. Resources need to be provided to it so that that kind of oversight can happen. These laws, at least the one in Oregon, is permissive and does not have the type of oversight that you're alluding to. And I'm very clear that it does not have the oversight that clearly some of the opponents would want. As was mentioned a minute ago, some of the advocates for this want there to be a lot less oversight and a lot less reporting. And so trying to figure out, that's why we stick with what's currently in the law. And if the law were changed, that would provide a different role for different parties.
Okay, time for one more question.
Question for Dr. Phillipson, if we may. And thank you for providing such a clear explanation of the Dutch situation. I noted that one of the main differences in the way things are done in the Netherlands is that individuals with dementia or cognitive impairments are not excluded from the process. So my question is, what protections exist for that group of individuals from exploitation?
Yes, they are not excluded. If I think best to look at the dementia issue in the law, it's not precluded. But here it's also good to look at the practice again. There are actually two groups that are distinguished in practice, and if you have early dementia and you're still competent, and you can still discuss very well with your doctor, and you say the suffering that is coming I cannot bear, then there have been several cases now. It's still also a very small group, both to ask for dementia, for euthanasia in that case, but also to certainly also to receive it. But that group is now more and more becoming clear that that has been gone well. So there needs to be really discussion, and there needs to be the second physician, and there needs to also be a geriatrician involved to check the competence and how, and so there is those kind of safeguards. The bigger issue that there is really struggle about, and according to the law it's not prohibited, is when there is an advance directive stating if I'm incompetent and I have dementia, I would want euthanasia. That can take the place of an explicit request, but then all the other criteria for prudent practice still have to be met, and that is very difficult, because how do you know that there is suffering then if somebody is really incompetent in the further stages of dementia, and how, and doctors are very reluctant in them. So I think they are the biggest safeguard to that. Also there's this same kind of consultation of many people, and that hardly occurs, because who will bring up that advance directive then? And if it occurs, it is almost always not granted. There has been 1 or 2 cases now reported, and one is the one that is going actually to court. So there will be new jurisprudence about that to make it more clear where exactly the boundaries are.
Thank you.
Thank you, panelists, and thank you, audience. And now we're adjourned until 1 o'clock.